So I'll go through everything, and I say at any point in time, please just ask if there's any questions that you have. There we go. So to start off with, so they do talk about neuroendocrine tumours as being rare cancer, and it is if you compare it to things like lung cancer and breast cancer. But we are finding actually that the incidence and prevalence is increasing, and certainly the more up-to-date data is showing it. Maybe it's not as rare as people think. It maybe just isn't being spotted. Neuroendocrine tumours, as I'm sure you're aware, they're sort of indicative of having symptoms and a hormone release, and there's some associated symptoms relating to that. They can be functional, non-functional, so you will have a syndrome or you won't have a syndrome, basically. And as you've already seen with the grading system, it can be all grades, so it can be slow, plodding, chronic form, but it also can be a very aggressive cancer, very similar to the high-grade cancers that we're all a bit familiar with in the news. What you should know is also that if you have a neuroendocrine tumour, then there is a 10% increased risk of developing a second cancer and adenocarcinoma as well. So what I always say to our patients is make sure that those national screening programs, all those sorts of things that you get through the post, you should still be doing all of those alongside the follow-up and things that we're doing for the neuroendocrine tumour. And unfortunately, what we are seeing from the majority of patients is that by the time they're diagnosed, it's already spread. So it's already in your liver, and the most common place for spread is the liver. So this, just in graphic terms, just goes a little bit about this incidence rise that we've been talking about. So this is the SEER data. This is American, but you can see this is general cancers incidence, and this is neuroendocrine tumours. So there's a massive difference in those graphs of the ambience. And down here, it sort of breaks it up into tumour types, seeing particularly the lung, midgut, and rectal, showing those rises over time. And the prevalence. So this is about living with. So again, what's really interesting to see is that you've got colon cancer and stomach cancer, all of these other cancers, and neuroendocrine tumours, more people living with it than stomach cancer and pancreatic cancer. But yet, if you ask people in the street, have you heard of stomach cancer? Have you heard of pancreatic cancer? Of course, yes. Why have they not heard of neuroendocrine tumours then? So there's an awful lot of work, and a lot of the charities are doing this internationally, and patient groups are doing this to raise awareness. To say this, okay, it's considered rare, but actually there's a lot of us out there living with this condition. And the patient experience. Now, there's many surveys that have been done both in the UK and internationally, and showing that on average, a third of neuroendocrine tumour patients are seeing their GPs 5 times at least before they're referred to see a specialist doctor. Now, that potentially won't be a neuroendocrine specialist. That might be a gastroenterologist because they've got diarrhea. So they say, okay, it's not responding, but it takes 5 visits minimum to get that next referral. And I'm sure, as I say, in the room, I'm sure you're not surprised to hear that. And also, if you look at the next statement, it's about seeing an average of 6 healthcare professionals before they're diagnosed. Again, you're going lots of convoluted routes to get to that next specialist. Lots of different places first before you get there. So it's really not good enough. And that's why, as I say, there's so much work being done over the years to get things better. Now, this is better than when I started 12 years ago. And 12 years ago, it was an average of 7 years to diagnosis. That has improved. It's still not great. It's still, I think the average now is 5 years to diagnosis, 4 to 5 years to diagnosis. So it's still not anywhere near what it should, but I liked at least those numbers are dropping. And that's what we want. No, that's fantastic. That's what that is. And what we do find is the most people that are diagnosed quickly are the ones that have incidental findings. So you get knocked down by a car, so therefore you need to have a scan. And therefore they go, oh, hold on, yes, I can see your hip bone there from the road traffic accident, but you've got something else in your stomach, in your abdomen, that we need to investigate. And those are the ones that are the lucky ones for getting knocked down by a car, because actually then they've been found when it's just in that one area, which they can take out, no metastatic disease, and there we go. So it is tricky. They call it the quiet cancer for a very, very good reason, because it sits there quietly for so many years. So where is it found? So I always think neuroendocrine tumour is not just about one place it can happen. Neuroendocrine, I think, is neuroendocrine tumours is really an umbrella term for so many different types of cancers and their behaviours within that. So they're often, when they talk about neuroendocrine tumours, they'll talk about foregut, midgut, and hindgut. sort of very original language that we've used over the years. And that's sort of almost where it developed, when it was embryonic stage. So when you talk about foregut, you're talking about the lungs. And if you think back to those graphs I was showing at the beginning, lung is the most common place for neuroendocrine tumours to be found. That's the most common type. Historically, we thought it was midgut, we thought it was the bowel, but actually more recent data is showing no, lung is more common. It can be typical, which means the slow plodding. They use different language for lung than they do for the rest, just to confuse matters more. So they use typical and atypical. So typical is slow plodding, atypical can be slightly more aggressive. Then you've also got the more aggressive type, which is the small cell, which is the grade 3 in there as well. They can be syndromic, so they can release some hormones as well, but the majority often don't. Then also you've got the stomach, so it can be gastric type 1, 2, and 3. It can be esophageal as well. You've got pancreas. So the pancreatic neuroendocrine tumours, the most common are the non-functional. So they sit there quietly, and it's only once they've grown to a certain size and putting pressure on different organs that they're often diagnosed or spread to the liver. Or the other type, which are the functional ones, so things like insulinoma, make too much insulin, gastronoma, make too much acid. So you've also got vipomas, too much VIP, glucagonomas, too much glucagon. So the hints in the name often with these sort of ones. Midguts. So as I say, historically, we always thought this was the most common. So that is a small bowel, basically, when you're talking about, and also the cecum, ileocecum, and you've got pictures where the duodenum is, they're asking where it was. So that's the bit at the top that connects to the stomach, and then you go into the small bowel, and then up to the large bowel. And the reason there's a heart on here is for people who do have midguts who are syndromic, will probably be already aware of this, is that if you have midgut, it releases, functional midgut, releases serotonin, which causes the carcinoid syndrome. That serotonin can also affect the valves of your heart. And they can become fibrosed, and so instead of snapping shut and pushing the blood around the body that they should be doing, they don't snap shut, and you have backflow of the blood, so its circulation is not as good. So that's something that is more, we've become more aware of this over the more recent years, and now it's standard absolutely to have your heart checked out at diagnosis and to be monitored throughout your diagnosis of your heart as well as everything else. So we can keep an eye, and we have a number of patients that have valve replacements just to treat that. It can also be the hindguts, the large bowel, you can see in the rectum. Appendix, and again, an awful lot of those ones which are incidental findings is because people have had a burst appendix, have the surgery. When any of us have any surgery of any type, they always test it and always look at the cells, and they're often diagnosed with neuroendocrine tumour that they've already had removed because of the burst appendix. And those often, the patients are, you don't need to do anything, they're cured instantly because they've had it removed. Goblet cell is a rare appendiceal type, more aggressive, and often those patients will also need to have part of their bowel removed, because that's the most common place it spreads to. So they'll have that second operation as a preventative measure to help reduce the risk of that. And rectal as well, neuroendocrine tumours. They tend not to be functional, this group, so they don't tend to cause that syndrome. It can also be in your adrenal glands, so you've probably heard of, there's adrenal cortical cancer that we include in the umbrella of neuroendocrine tumours. You've also got pheochromocytomas and paragangliomas. They affect the adrenal glands and they release adrenaline. That's their hormone they affect. So these people are constantly on alert. If you think that fight or flight hormone, so they could be trying to have some sleep, and they're having this adrenaline surge and their blood pressures are shooting up and that sort of thing. So very, very unpleasant. And what they do is they have a adrenalectomy, so they remove the adrenal glands to control that. Thyroid, so medullary thyroid cancer, which secretes calcitonin as well, we look after. And the skin is there because there's a form of skin cancer called Merkel cell carcinoma that also comes under neuroendocrine tumours as well. A lot of people will also ask, well, what about my kids? Is this going to have an impact on my kids? Is there a genetic component in there? And there is 10 to 25% is associated with that genetics. And it's known as medullary endocrine neoplasm is the most common type of genetic syndrome, if you like, that it can be associated with neuroendocrine tumour. Type 1 is the 3 Ps, pituitary, parathyroid, and pancreas. Type 2, medullary thyroid, parathyroid, and pheochromocytomas. So when you go and have your diagnosis, we will automatically, if you have a pancreatic neuroendocrine tumour, they'll also check your PTH, parathyroid hormone, calcium levels. And that's a nice sort of screening, low-level screening that we can do for this. Because if those levels are abnormal, then that sets alarm bells to us to say, okay, we need to send this person for some genetic screening. Okay? There's also 2 other genetic syndromes which are associated with which include neuroendocrine tumours. There's von Hippel-Lindau, which you can see the pheochromocytomas can become part of that, and neurofibromatosis, again, with pheos and paragangliomas. So again, if we have patients that have more than one cancer, then again, we'll be thinking, at diagnosis, they've got a pheo, but they've also got, looking back at their history, they had a renal cell cancer in their past. So, okay, we need to, again, send this person for genetic screening and just check to see if he does have this. So when I talked about the syndromes, I'm sure you probably, I did miss a couple of the first talks, so I do apologise if I'm repeating lots of things for you. But the syndrome that some of you guys will have experienced is the carcinoid syndrome, which is the diarrhea, flushing, palpitations, the carcinoid heart disease, which is CHD, that's what they've shortened to that, and wheezing. And it is 20 to 30% of people with midguts who will be functioning, so a majority are not. And Zollinger-Ellington syndrome is the gastronoma, so that's the pancreatic neuroendocrine tumour, but that can also be found in your duodenum. That releases excess acid into your stomach, gastrin. These people have peptic ulcers that just don't heal because the acid level just continues and continues. So these people are often diagnosed with repeat endoscopies over the years. They've had bleeds, ulcers. They also have diarrhea because you've got too much acid in your stomach and that moves into the bowel and kills the gut enzymes. So that means you eat your food and there's nothing to help you absorb it. So these people are very indicatively cured of diarrhea by having lansoprazole, omeprazole, those antacid medication. We've had a number of people that have been referred to us because the gastroenterologists have picked up on the fact their diarrhea has got better after being given an antacid medication. So that's not normal. Okay, we need to find out what else is going on here. Insulinoma, as I say, the pancreatic neuroendocrine tumour that puts too much insulin, so they sugar levels, no matter how much you eat, the sugar levels just keep dropping because you've got too much insulin breaking it down. So unfortunately, it can be so dangerously low that they have to eat continuously to keep their sugar levels up. And they're often having to be in hospital on glucose drips to maintain it until you get the tumour under control. Werner-Morrison syndrome is the VIP, vasointestinal peptide, a pancreatic neuroendocrine tumour that releases that. And people have watery diarrhea, and they're often in ICU, intensive care units, because the diarrhea is so bad. If you stop eating, you stop drinking, you still get diarrhea continuously. So again, you have to get that syndrome under control for people to get quality of life before you can actually treat the cancer. And glucagonoma, so they have too much glucagon release, so their sugars are too high. It's the opposite of an insulinoma, if you like. So again, we have to get their sugar levels down to safe levels, and they also have an indicative rash. So for all of these, there are treatments that we do to control the syndrome, and for a lot of people that's the priority number one. We can't even think about treating the cancer until we get people feeling well, feeling strong, so they can cope with any treatments that we're talking about, if that makes sense. And just so you know, I'm not going to go into massive detail talk about them, but there are also other hormones that can be released. So these are the rarer ones, but SIADH, which is the top one, other lung cancer patients will have experienced that as well. So this is not just neuroendocrine tumours that can have this syndrome. You'll see other cancers can have it. PTHRP, it's too much PTH, so therefore your calcium levels are constantly high, which can make people very confused and drowsy and very unwell. And Cushing's syndromes is the adrenal glands. So too much cortisol levels, very, very unwell. And we have some patients who have to have a bilateral adrenalectomy, so you take the adrenal glands out to stop this syndrome, and that's nothing to do with their well, it's caused by their cancer because it's the too much hormone, but then you have to go back and treat their lung neuroendocrine tumour, which is actually where the cancer is. But you can't touch that until you've sorted the adrenal glands out. So how do we diagnose you? So I've said that there's this mass of symptoms that might be happening, and if you have a functioning midgut, for example, you have diarrhea, flushing, oh no, you've got IBS and you're menopausal. no matter what your age is. They always say that. And to men even, I'm not quite sure what they say the menopause thing, but you do have a gentleman flushing in front of you and it still doesn't trigger, unfortunately, because the awareness is not there. It doesn't trigger immediately, hold on, this is a neuroendocrine tumour, and that's what we need to change. So suspected neuroendocrine tumour, so most of the people that come to the NET centre will already be diagnosed with a neuroendocrine tumour. That's why they've been referred to us. It's very rare we diagnose ourselves. It's in a specialist unit, unless you happen to be local. And then it will be us. But most people are already diagnosed, and then they come to us. So what we want people have been done, if you're suspecting your endocrine tumour, there are tumour markers that you should be having done, whether that's chromogranin, the 5-HIA 24-hour urine for midguts. There's a fasting gut hormone profile, which is for the pancreatic neuroendocrine tumours, so checking your VIP, insulin, all those levels are included in that. Pituitary screen and calcium, that's what I was talking about for your MEN1. There's multiple endocrine neoplasia, so we want to make sure that screening's happening automatically. And PTH is all part of that. The gold standard, absolutely, the diagnosis, and as they've said in the MDT about treatment plans, is histology. That's what we need. We need tissue. Now, that might not be from a whole, from the surgery where they've taken your primary out. Most often it's biopsies of your liver, because that's the most common place that it'll be spread, or from the primary. A lot of centres will do two, one in the liver met, say, and one in the primary, because they was looking earlier that they can have different behaviours. The problem we also have is that different tumours within the liver might behave differently. So which one are you going to go for? And they'll often, they're looking at doing an FDG PET and a gallium PET, right at diagnosis, to say, okay, which are the ones high, if there's any showing up glowing on an FDG, biopsy that one, because they're the more aggressive. We need to know what that one's doing, because that would be the dangerous one, if that makes sense. They also, the future, is going to be about biopsies, is going to be about, my words have gone now, but you have a blood test, liquid biopsies, that's what they're calling them, where you can just be able to have a blood test and circulating tumour cells will be picked up and that will tell us the information. We'll be able to get DNA from that. That's where we'll be able to sort of look at matching treatment directly to the tumour type you have, which will be different from yours, even if it's all mid-gut neuroendocrine tumour. So this is what the future is going to be looking like. The scans that we want people to be having is CT scan, is the gold standard as well. And an octreotide scan or a gallium PET, which is what we were saying. So we want to look at the functionality. So a CT scan will often be chest, abdomen and pelvis. Even if you have a lung, we want the chest, abdomen and pelvis. We want to make sure that has it spread anywhere. Gallium 68 PET is our entire body, which is brilliant. So it gives you that reassurance. So if you're going to be having surgery and they've found that primary, let's say it's midgut, okay, but before you have surgery, we want you to have a gallium PET, because we want to know, is that really the only place? Because it might not have shown up on the CT. Nothing is 100%. So let's do a gallium as well and just be reassured that you're going to be able to get rid of everything. So once we've got all of those, there's also those specific tests at the bottom. Don't worry, I will not talk about all of them, otherwise you'll be falling asleep. But depending on what type of neuroendocrine tumour we're suspecting, and we get these answers as we go along, it's never just one test, it's a combination of everything and your symptoms. So you need to be very much telling your doctors and your nurses, this is what I'm feeling, this is the symptom. It might seem really small to you, but we need to know, because that all adds to the picture of trying to get this diagnosis correct for you. And as I say, there's like echoes, as I talked about, for midguts, to make sure your heart's okay, and that'll be ongoing monitoring. If you're gastric, you'll have an endoscopy, always a pleasure, but you will have to have an endoscopy, I'm afraid, to have a look at that and take biopsies. So it was very much individualised. So if you're chatting to each other in clinics, for example, you're all waiting there, and one's got a bronchial, one's got a midgut, for example, and you're chatting, you will have had different things, and that's okay, as in tests, because that's how it should be. There should be some differences because of what your individual diagnosis is, okay? And how do we treat it? Now, I've already heard, and I have to say I was extremely shocked to hear, that you're not able to get some of the standard, what we consider in the UK standard treatments. And I hear that in the background lots of pushing is going to continue to go. I know the charities and you guys are going to be the most influential people for that. And I would say keep pushing. We've had similar issues in the UK. I don't know if you hear about for PRRT. We've only just got it back on, but we've had 2 years where we couldn't give it. Thankfully, it's now back on and we can give it. Fantastic treatment. No treatment is easy. There is always side effects for all treatment, but it is generally well tolerated and it works for the majority of people. As long as you're gallium positive, it's a very good treatment to have. So keep pushing. It sounds like it's coming, which is fantastic. So yes, go on. Yeah, so the most common... Yeah, so if you think about, I keep going back to midgut, for example, I think it's about 90, I might be misquoting now, but a very high percentage of midgut neuroendocrine tumours. The well-differentiated, low-grade neuroendocrine tumours tend to be gallium positive. The high-grade, poorly differentiated, tend to be FDG positive, not gallium positive. Okay, they do have some high grade, well differentiated, so that sort of is aggressive, but you've got some well differentiated that can be gallium positive, so that opens the door for that type of treatment option. But there's absolutely no point having a lutetium treatment, which is a PRT, or somatostatin analog injections if you are gallium negative, because it's nowhere to go. Those receptors are missing, so it's not going to help you, if that makes sense. So that's why these scans are very good at diagnosis and throughout your treatment plan and your treatment journey that they sometimes talk about. Because also that can change. So we've had people who are gallium negative that after treatments and things, you check it again before you sort of looking at the next, and some are positive now. So there's transformation that can happen inside as well. And also some were gallium positive and some are transformed to being FDG positive over time. So it's really important that we know that. So that's where all these things come together.
I understand that the octreotide and the lanreotide can also be effective at reducing sometimes the size of the lesions even though you've got negative.
Yeah, so we've been using it, again, which is why I was quite shocked. So we've been using it as standard treatment now, lanreotide and sandostatin LAR, which is the long-acting octreotide, since the PROMID and the Clarinet research, which was probably, I think, a couple of years now, as standard for any newly diagnosed. So that covers midgut, it covers pancreatic, well differentiated. So anyone who's gallium positive and lung, well differentiated and got a gallium positive, first line treatment. It helps maintain stability is the most common thing it does. So they've shown that if you have no syndrome, but you have these injections over time, it's less time to progress if you're not on injections compared to being on them. You see what I mean? It delays that next treatment option. Does that make sense? So I think keep pushing, because that's a really important treatment that you guys should be having access to. It's a very small percentage. I know you mentioned about shrinking tumours. It's a very small percentage that causes tumour shrinkage. It's about maintaining stability, yeah? So just so you're aware. And what they're looking at, there's more research going on at the moment where someone, for example, let's say had chemotherapy, who are gallium positive. They've had chemotherapy that's shut the cancer down and it's under control. And then you have scans to monitor it, and at some point it will wake up and grow, and then you need more chemo. What we're looking at now is research is saying, okay, you've had that chemo, then you get a somatostatin analog, so lanreotide. I think it's lanreotide the study is looking at. You've had a gallium to show, obviously, it's positive. Then you get put on lanreotide, and they're seeing if that makes a difference to delay. So the next chemo is not needed for a bit longer because you're on it, and that's what we're looking at now. Logic says yes, but we can't prove it yet. So that's not written on as an indication for use yet. But it makes sense to me, it's common sense to me that should help. So I'm expecting it to show that it does help. So that's something that we're sort of hoping to bring in. So this is from ENET, so this is a European standard it's very messy is probably a good word. So you have many different options. What a lot of the studies are looking at now is what order should it be in, because at the moment there isn't lots of answers about that. We'd use somatostatin analogues first line. That is pretty much out there. We do also still use watch and wait. So there are some patients that with a discussion will say, well, actually, I don't really want to have injections which are going to give me side effects because I feel pretty good, actually. I feel fantastic. I wouldn't know it was there. So why would I want to have something that makes me feel potentially a bit rubbish, gives me diarrhea as a side effect, if I feel fine and my tumours are under control? Good. As long as that's an informed decision, that's absolutely fine, of course. So people do still do watch and wait and then have scans. And then if it starts waking up, that's when we'll step in with the somatostatin analog as that treatment. Does that make sense? So it's sort of staggering things. And then if you've got progressive disease, then we've got the lutetium. MIBG therapy we don't really do very much at all anymore. That used to be the standard treatment before lutetium, which is used now, and before yttrium. So we've got various different drugs over time that have changed. The chemotherapy. So I know the colleague before me, the doctor, was talking about temozolomide and capecitabine. So we often will use, so streptozotocin and temozolomide are the same type of drug. So we in our centre use streptozotocin, but it is the same, pretty much the same drug. It doesn't really matter. Sunitinib and everolimus. I don't know if you guys have that here, but it's an oral agent, a tablet. That's now just research has shown that it's effective against pancreatic, neuroendocrine tumours, lung as well. So that's another treatment arm for you guys. And then the poorly differentiated is pretty much chemotherapy is the goal, is exactly what you should be having, and that's the treatment you should have. But we also do the liver-directed treatments, which is the embolization, the ablations, which again was discussed in the talk previous to us. We also have interferon, which is a treatment that's been around for years and years and years and years and years, and that is still used, and certainly a lot of the European countries do use that for tumour control and to reduce functionalities. So if someone is intolerant of somatostatin analogues, the octreotide and lanreotide, and functional, so they're having syndrome but they can't take these drugs, then interferon is often given, and that can work very well as reducing the functionality. But it's not an easy drug, so we're very careful about who we give this to and make sure that the person is well enough to have the drug. And they're monitored very closely. So before I move on to a centre about what it is, does anyone have, I know it was a very brief overview, but is there any questions from anything I've just said? I bombarded you probably with all of that, didn't I? Okay, does it all make sense? Good. You've got a question?
In the UK, do you give both types of schemes, the FDG scheme as well as the...
So not everyone all the time, and it's something we're seeing more. I suppose in the last couple of years I've started seeing it a lot more, and it's because we've started to see this transformation, and actually there's an awareness actually that you can have more awareness that you can have, say, several tumours and some behaving completely different to others, but all within the same in your own liver, some behaving differently. And rather than what we don't want to be doing is biopsying every single different lesion, because that side effect, pain, risk factors, you don't want to be doing that. So then FDG PET and a gallium PET is a really good way of doing that for us without having to stab you, if that makes sense. So it tells us that information of what's expected behaviour, because we can do that. So we are using it more and more, but not every centre will do it exactly the same, because it's not written in the guidelines saying you have to have this. Yeah.
You're talking about the ambulance at the bottom of the cliff. What about providing an ambulance at the top of the cliff? Is there any research or anything being done to say take 10,000 people and monitor them with, say, chromogranin A or something, and see any changes, and then say, hey, we think you might be in line for...
Like a screening tool, is that what you mean, screening?
Yes.
Yeah, so unfortunately it's very difficult. So chromogranin can be raised if I have diarrhoea, if anyone has diarrhoea without any neuroendocrine tumour, it can go up. If I have kidney issues, it can go up. So it's not by itself a very good screening tool. They're looking at all of this. So there's lots of research going on internationally at all aspects of whether it's the order of treatments, the types of treatments, how to diagnose it, the histology. Every single step, lots of research is going on. But you're absolutely right. The ideal scenario is that we can find this before it happens. Or as soon as any symptoms or anything happens, there's this could be neuroendocrine tumour, let's get the investigation starting and reducing that delay. You're right, there isn't a good screening tool there, and chromogranin wouldn't be the tool to use. Serotonin, so the 5-HIA 24-hour urine one, I've had patients who've Googled their symptoms, and they go, I should probably have one of those. Go to their GP and demand one. I want a 24-hour urine, thank you very much. They have it, and it's high, and then we get the referral, and they have multiple mid-gut neuroendocrine tumour with multiple liver metastases. So it's a patient sort of led change, but that GP, you can bet will never do that again. Will always, if they have anyone with diarrhoea that's not responding to their IBS medication, will be checking this 5-HIA straight away. So, but we don't want it to be that way, but we need everyone to think neuroendocrine tumour for these symptoms and start building it into their repertoire of knowledge.
If you've got a family history, how do you what do you do? Go to your GP and say, what, I want to be screened for what?
Yeah,
so
so
you've got no symptoms of anything that you can pinpoint,
yeah.
But obviously...
So it depends. Yeah, it depends what genetics it is. So for we have endocrinologists that work within our service, and so for the pheochromocytomas and things, there are like BRCA genes, but it's not that. We know BRCA you've heard of for the breast cancer one, but they have sort of certain genes. If you have that, and you say your daughter or something has it, then they know that at some point potentially you will get, potentially, it's always potentially, that you're more likely to get neuroendocrine tumours. And we have their family members that come to our centre, and we're screening them with MRIs and blood tests and the specific urine, the specific blood tests for neuroendocrine tumours. So it's what you were talking about really, but we do that. So if you have a known family history of a genetic syndrome, and that's a very important difference, if you have someone in your family who has neuroendocrine tumour, it doesn't mean that you're going to get a neuroendocrine tumour. There is, like any cancer, if any of, unfortunately most of us have it in our family, don't we? And therefore you do have a slightly increased risk of developing cancer if you have someone with cancer in your family. And that's the same with neuroendocrine tumour as it is for other cancers. So you just have to be very careful. What I would say, not careful, but very self-aware of your symptoms and how you're feeling. We have had patients and relatives of patients who've said, my mum had, lung neuroendocrine tumour. I'm really worried. I'm feeling a bit unwell, and obviously this is why my concern. I'm just worried. So what would you recommend? And we say, okay, well, you either can get your GP to refer to us, or we just recommend you have these tests, and that will put that worry to rest if they come back negative. That sort of thing. So you can always ask either the charity here or your specialist centre, your doctor, about what specific things they should be looking for.
How do you find out that the family that's got it? How do you find out that it's carrying the
So if they've got this combination of tumours, they'll go for genetic screening, and that's where they have a blood test that looks at their DNA and checks if they... So it would just be whoever your doctor is, your endocrine tumour doctor, they'll be able to refer you. Yeah. Oh no, 5 minutes. Oh, right, quick. So Centre of Excellence. So just so you know, this is what they're hoping to bring here. Okay. So the Royal Free one, we've now just had our 20th year anniversary of Neuroendocrine Tumour Unit, and we started off with 30 patients, and now we have. Now it's even higher than that, over 2,000 patients that we actively see every year. We are a Centre of Excellence. We became one in 2011. The team that they were talking about, that multidisciplinary team, that is absolutely critical for neuroendocrine tumours. It's so essential because it's so complex, because it covers so many different things. Your treatments might be surgery, it might be ablation, it might be chemotherapy, it's somatostatin analogues. So all these specialists need to know about neuroendocrine tumours and talk to each other and be in the same room in those multidisciplinary team meetings to get their expert opinion, looking at your scans and looking at your symptoms. Dietitians, extremely important. Obviously nurses as well. I don't think I've got nurses on there. Oh yes, I have. No, I'm there. But obviously the most important thing is you. So often with these meetings, the person that is your voice is the nurse, because often they're the ones that you'll talk to the most and talk through your symptoms with. So they'll be the ones that be saying, actually, yeah, they have got that symptom. So that would make sense. And then at the Royal Free, we have a meeting every week. Different centres have them at different frequencies depending on the number of patients they have. I'm not going to go through this, don't worry. But this is just showing that very important criteria of a Centre of Excellence is you have to be active in research. So this is some of the active research projects that we've been having going on at the Royal Free. What difference does it make if you're going to go to a Centre of Excellence compared to a non-Centre of Excellence? And this was a study where they looked back, the SEER data, and they compared patients that had all net patients compared to patients that had been treated within specialist centres and Centres of Excellence. And you can see the median survival is dramatically increased if you've got that knowledge, if you've got that access to that knowledge and expertise and those treatments that you need. And it's not about just having the treatments, it's about having the treatments in the right time. The other things that we're doing is we have nurse-led telephone clinics where you have specialist nurses such as Avril and things where they know about neuroendocrine tumours. You ask them a question, they know what you're talking about. They can compare it to someone else and have that conversation with someone who knows what the advice that will work for you. We have a carcinoid heart disease clinic as well, so we talk about the valves. So a cardiologist who knows about neuroendocrine tumours has a specialist clinic once a week as well. We also have the head and neck for the pheochromocytomas, carotid body tumours. Dr. Bernard Koo does an awful lot of work for that. The nurse specialists we're all nurse prescribers, so we can prescribe the medication. So we can see you if you feel unwell, you come and see us in the clinic, and we can go through your symptoms and we can prescribe the medication that we think that will help you. So we do it all sort of very nice, seamless care. This is just an example of some of the pathways that we use to get to treatments. We also are you have partners as well within the Centre of Excellence, and so you don't expect each hospital to be able to do everything, because that's not often realistic. Most of it, so we will have, say, the lung surgeon works at a specialist lung hospital, but there's a contract that's signed and agreed, so that pathway is seamless, not, you have to go back to your GP before you can get referred to there. No, we can just do it. We can have a phone call. They'll be in the MDT, even if it's electronically in the MDT, not actually there. But we can get all those pathways really slickly done. We also do an awful lot of work for nationally and internationally for awareness, for knowledge, teaching other nurses. So for nurses in smaller hospitals who may have a couple of patients, we want them to know what they're doing, want them to be able to give their right advice and care for their patients. It's constantly changing, and we also want to make sure we're reacting to that change appropriately from a hospital and care point of view. So it's lots of audits. I'm sure you often get lots of questionnaires about making sure, are we doing the right thing? Hopefully. Are we doing the right thing? What can we do better to make sure that your care is as it should be? So that's what the audits are, obviously making sure that we're kept up to date. And the ENET's Centre of Excellence is a 3-year in-depth, but every year we have to send our data to show that we are seeing the right number of patients, that we're acting as appropriately following the guidelines, following those treatment processes, the diagnosis processes. And then from a nurse's point of view, and the doctor's point of view, we also do a lot of teaching, and you can see that preceptorship within Europe, China, Australia, to try and get the word out about neuroendocrine tumours. And this is our happy group. Smiling after our Monday clinic, still smiling. So that's what I'm saying. So you've got that wealth of knowledge. So even though you're seeing one person in front of you in your clinic, all of these people have seen your scans earlier that week. So they've all put their expertise into that next treatment, that next step. This is the advice that, this is what we recommend that you should be doing.